Okay. Sure. Okay. I'll start with the norm. Good morning, everyone. I'm Bonnie Lysyk, the Auditor General of Ontario, and I'm here to talk about my office's special report on COVID-19 preparedness and management. This report contains 3 audits. A second special report containing 3 additional audits on COVID-19 will be issued in the near future. Today's 3 audits looked at the province's initial response to the COVID-19 emergency. Our objective in conducting this work was to provide timely information on lessons learned that can be applied going forward as the challenges of COVID-19 continue. I'd like to extend a special thank you to Assistant Auditor General Rick Kennedy, Directors Gigi Yip and Wendy Kumbo, and Manager Michael Yarmolinsky and their team for their work on this special report and for their dedication to the mission of our office to serve the members of the Legislative Assembly and through the Assembly, all Ontarians. I'd also like to further acknowledge Wendy Kumbo for her excellent work during her almost 24-year career with the office. Wendy postponed her retirement to complete Chapter 1 of this special report for the members of the Legislature. And Wendy's to my left there. The COVID-19 pandemic presents a challenge to health experts and government decision makers around the world that in many ways is unprecedented in its impact and complexity. Decision makers, the healthcare system, and the public all made a determined effort to ensure that Ontario's health system would not be overrun in the first wave. Ontario and Quebec were the 2 provinces hardest hit by the first wave. We can be grateful that the worst-case scenarios initially anticipated did not materialize. Ontario would have been much better prepared to address the challenges of COVID-19 had it addressed many of the recommendations in past reports from the SARS Commission, from our office, and from others. Overall, we found that Ontario's response to COVID-19 in the winter and spring of 2020 was slower and more reactive relative to other provinces. We also found that the Ministry of Health did not have available, when COVID-19 impacted Ontario, coordinated and effective systems and procedures in place that could be relied upon and easily be adjusted to perform timely COVID-19 lab testing, case management, and contact tracing. Improvements continue to be needed in these areas to control and prevent the spread of COVID-19. Long-standing systemic issues, such as outdated and largely untested emergency management and pandemic response plans, limited lab surge capacity, deficient lab and public health information systems, a fragmented public health system, along with a health command structure not fully led by the Chief Medical Officer or dominated by public health expertise, complicated Ontario's response to COVID-19. In our audit emergency management in Ontario pandemic responses, we found that the province was clearly not adequately prepared and trained for an emergency of this magnitude. We brought this state of unpreparedness to its attention in our 2017 audit on emergency management in Ontario. However, we found that in the past 3 years, only 4 or 11% of the 36 recommended actions that the Ministry of the Solicitor General was responsible for have been implemented. The Ministry oversees the Provincial Emergency Management Office, the EMO, is to lead province-wide non-health-related emergency and/or pandemic responses. EMO is responsible for the Provincial Emergency Response Plan for Ontario, while the Ministry of Health is responsible for the health-related response plans. With COVID-19 impacts beyond the health response of leading critically important public health measures, EMO would normally coordinate the many other aspects of emergency response, such as ensuring that municipalities are immediately informed of actions to be taken and relations with the federal government. When COVID-19 hit Ontario, the province was not in a position to activate the provincial response structure in its emergency response plan. This was partly due to having outdated emergency response plans, dating back to 2013 for the Ministry of Health and 2006 for EMO, and a lack of sufficient staff and government and oversight processes for emergency management. Instead, on March 25, 2020, the province hired an external consultant to create a new governance structure after Ontario declared a state of emergency on March 17th. The consultant's final report was delivered on April 24, 2020. In contrast to Ontario, other provinces were able to activate existing response structures and had updated emergency response plans. The new governance structure did not give EMO a prominent role. Our audit on outbreak planning and decision-making found that Ontario's response to the pandemic has been hampered by a cumbersome command and advisory structure. On February 28th, the Ministry of Health established a health command table to provide advice to the Minister of Health, Cabinet, and the Premier regarding Ontario's COVID-19 response. The health command table grew larger and more complex over time, starting from 21 members with no subtables, then expanding to 83 participants, consisting of 32 members and 51 attendees as of August 31st, plus 25 subtables. In total, more than 500 people are involved in the health command tables. This structure should have been dominated by public health experts, but was not. We found that Public Health Ontario's expertise was not always sought. Regional tables were generally led by hospital CEOs and staff from Ontario Health, not public health experts. The structure is vastly larger than the structures used by other jurisdictions, which have made better decisions faster in areas such as testing and long-term care. We also found that the Chief Medical Officer of Health was identified as a co-chair of the Health Command Table on March 6th, but the terms of reference were not updated to reflect this, and he did not chair any of the meetings. The lessons learned from SARS were to act quickly to put precautionary measures in place, but we found there were delays. Such delays included alerting Ontarians to avoid unnecessary travel, acknowledging community transmission, and requiring long-term care homes to take precautionary actions. As the pandemic progressed, it became evident that it is critical to identify individuals with COVID-19 on a timely basis through lab testing, case management, and contact tracing in order to prevent them from spreading COVID-19 to others. Our audit on lab testing, case management, and contact tracing found that the Ministry of Health did not take immediate actions to ramp up testing capacity, despite warnings by Public Health Ontario and experts in February 2020. It was not until a month later in March that testing capacity was increased with assistance from community and hospital labs. Despite this, the ministry fell short of its own targets for lab testing. 60% of lab tests were to be collected within 1 day of specimen collection, completed within 1 day of specimen collection, and 80% within 2 days of specimen collection. However, the province overall has not met these targets. Only about 45% of tests were completed within 1 day, and 77% of tests were completed within 2 days between March and August 2020. The regions that fell behind in lab testing included the hotspots of Toronto, Peel Region, and York Region. We also determined that as of March 31st, 2020, possibly 119,000 Ontarians who might have had COVID-19 were never tested, partly because the province was not able to test anyone with symptoms who requested a test until mid-May. Our audit found that Public Health Ontario informed the Ministry of Health in 2017 of the risk of its inability to comprehensively respond to emerging public health threats due to a lack of sustained funding. However, the ministry reduced Public Health Ontario's funding by about $13 million, or 9% in 1920. Between 14-15 and 19-20, Public Health Ontario decreased its numbers of full-time equivalent staff by 120, representing 12% of its workforce. Several important thinkers have pointed out over the years that those who do not learn from history are doomed to repeat it. In closing, on behalf of my office, I want to thank the many people involved in our work for their assistance and cooperation in the completion of this special report. Finally, I want to thank those in the healthcare sector and the various subject matter experts, including Dr. David Walker and others who shared their knowledge and advice with us. In particular, we also want to thank the frontline healthcare workers and lab technicians. Now I'd be happy to take your questions.
Bonnie, I know that this, when you've given previous audits, you've gotten this question before, but I think it bears asking again, because a lot of this has to do, as you pointed out, with not implementing previous recommendations that you've made, that previous reports have made while the Liberals were in power, but also acknowledging that there are obviously critical decisions that you found that impeded the response. Can you speak to how much each government kind of wears in this, in terms of the lack of implementation in the previous government, but also the current decisions that this government has made in terms of responsibility, accountability? How much does each party wear in that?
I think, a lot of the reports that we've identified in this report, and a lot of the reports in the years where recommendations were made, are over the last 15 years. So whoever's governed over the last 15 years, has delayed implementing recommendations that were meant to improve the lab systems and the public health unit information systems that during COVID-19 were really important to have in place and used during the course of this emergency. So, it's kind of luck of the draw who's in the position of government when the systems that are supposed to be there when you need them aren't.
The health minister was up here before you. She mentioned that you spoke to her, and that they responded to your reports before, but this was a very almost come out swinging defense of the government's response to this, and used words like mischaracterization, different factual findings. When you get that type of pushback from the current government, what do you think of that?
I guess I'd have to say that it was a little unexpected, but here's our process. So we do our work, we write our reports, we bring in expert advisors to work with us. We have our reports, our findings, factually cleared for accuracy. We have our draft report reviewed for factual accuracy. We ask for responses to our recommendations. We incorporate those in our report, and then we get a letter signed off at the end of our audit by the groups that we've been involved with to attest to the factual accuracy of the report, that they've provided us with all the information, and if there was anything that was wrong in the report, they have an obligation to tell us. And so in the cases of these three reports, we have letters signed off by the Deputy Minister of Health, the ADM of Health, Public Health Ontario, Ontario Health. So we have, I guess what I'd say is I stand behind the reports, I stand behind the factual accuracy of the reports, and I think our intent in issuing these reports is not to say, everyone was caught off guard during this, and people make the best decisions they can in a type of crisis. But what we're saying is, in a time of crisis, the systems that people needed weren't in place. And we're showing what the consequences of that are. So going forward, these reports are meant to take us forward into the next decisions that are being made as we go forward, because there will be many more decisions that will have to be made until COVID-19 is passed, but also until when the next emergency hits. So I think, it's unfortunate. I think the Secretary of Cabinet agreed to all these responses, and the ministry. So the responses that are embedded in the report are positive in a sense that they're going to go forward and make changes. So I just hope, that at the end of the day, this is not, the intent behind our work is not a blame game here. The intent is to make sure that the issues that have been highlighted finally get addressed, because it's been, 15, 20 years that some of these things are still not fixed in Ontario.
Just one more for me, Colin, quickly. And are you concerned about the timing of this? Did you think about delaying the report until kind of after the pandemic had rolled? Because now we are in the middle of this pandemic. Right. Now the government has to respond to it. There's a lot of serious stuff in your report. Did you think about Why?
Oh, most definitely.
Why now and not later on, when
Yeah.
as a post-mortem maybe?
So the introductory letter for this work was sent out in May, and at the beginning, in May when we were doing all of our work, you kind of question how much can you do remotely, and I have a fabulous team, and we did a lot remotely. But I did pose that question. I said, do you think we'd like to start looking at this? The intent of looking at this is to put forward recommendations as soon as we can that will help point out any issues that need to be addressed. It takes a while, all right, during a period like this to get information, to talk to people, not to be overwhelming to a group that was facing, work in a pandemic. And they were receptive. The province was receptive. I even got a letter from the Secretary of Cabinet, I believe, that supported our continuing work on value for money audits. And in fact, senior people in the government were supportive of doing this. So, until that happened today, I'd say, I think it was a good process for everybody, and we were very understanding of people's commitments. The other thing about our report to keep in mind is it's not us writing down, these findings. This report is from surveys of the municipalities, surveys of the public health officials, many discussions with the Chief Medical Officer of Health, many discussions with Ontario Health CEO, discussions with the Ministry of Health. So this collectively is their message.
Can you expand on Dr. Williams' response and involvement compared to other chief medical officers of health in other provinces? You mentioned, for instance, Horacio Arruda in Quebec. Did he, call the shots more often? Was he more independent, for instance, than how did William has responded?
I'll use BC as an example. So BC, pandemic hits. There's two emergency orders. One health emergency order gets passed, and that is under the control of the public health official, and that would have been similar to the CMO here, the lady there, Bonnie Henry. The Premier then would pass the Emergency Measures Act, and that took place there. The decisions and the spokesperson for the health side of the pandemic would have been Bonnie Henry, and her reporting relationship parallel, she would go right into an emergency mode. So her normal reporting is into an ADM in the Ministry of Health. She would go right into a separate reporting parallel with the Deputy Minister of Health and make the decisions. And she did make the decisions throughout the pandemic and publicly communicate those decisions. So what we have here is we have an advisory process versus this is not a personal thing for the individual in the role. The fact is, in BC, they've modeled it that way, and it allowed the health side to have a voice in the public way.
Did Dr. Williams lack some leadership in his decision making? You're saying he didn't call all the shots that he could have in his report. He could have helped, the local bureaus coordinate better in their response, stuff like that, didn't use the full extent to his power. So did he lack leadership?
So the public health units, in a couple cases, would have appreciated more guidance. So, he could have provided more guidance to the public health units. I think the reporting relationship was into an ADM. So, there's a respectful reporting relationship there. And you have to remember, too, this is probably the first event after SARS where really the SARS reports led to the creation of Public Health Ontario and a stronger role for the Chief Medical Officer, where somebody had to sort of take that role and go with it. And there's a comfort around doing something like that and being more public on something like that. So I think at the time we've had conversations with the Chief Medical Officer, and he knew that he was part of a team and providing advice into a team.
Are you saying he was uncomfortable with being kind of a public face of the pandemic response in Ontario?
I'd say the system that was there, he worked with the system that was there.
We're going to go to the phone lines for questions, and I think we have quite a few callers on the line.
Yeah.
Go ahead.
Rob Ferguson, Toronto Star.
Hello, Auditor. I wonder what you make of the criticism from some people and some on the government side today that your role is as a fiscal and financial watchdog, and you're kind of venturing into other areas that makes this look like mission creep.
Well, we had lots of good discussions before we started this work and before we start our value for money work. The reports have all been signed off as providing good information, factual information out there. There's recommendations that were accepted. So if you in the report, you will see the recommendation and the response from the ministry or Ontario Health or Public Health. And I don't think that's the case. I think we did our job. Our job is to report to the legislature information that we bring forward from our work, and I think that's exactly what we're doing. Yeah.
All right, but since your role is, as outlined in the statutes and the job description, I'm wondering. My colleague Robert Benzie today had a story on the front page of the Star that $11 million was stolen from COVID relief funds. I'm wondering why you haven't highlighted that. That's a fair amount of money, and it seems kind of tailor-made for an auditor to dig into.
Yeah, I mean, in this particular case, we do have, we are tabling 3 reports after this one, and one of them is called COVID expenditures.
Sinead Dugal, Queen's Park Briefing. Hi there. Thanks for taking our questions. I just wanted to get your response to a couple of points that the government gave to us today in response to your report. One of the things the government noted the part about the fact that Public Health Ontario did not support the expansion of testing to all asymptomatic Ontarians. They said they did this as a precautionary measure when they had capacity, but they also noted that you said in the report there was a lack of testing to all travelers at the border, something they said that would need a boost in asymptomatic testing. I'm just wondering what your response is to their counter-arguments on this.
So the advice to the Health Command Table by Public Health Ontario was that asymptomatic testing was not necessary, and what it would do would put a huge volume impact on the testing speed in the labs, such that people who would have positive results would not know fast enough, and then case management wouldn't start enough. So it was advice from Public Health Ontario to the command table regarding the asymptomatic testing. And the way that was defined is people that have no symptoms and have not come into contact with anybody with COVID.
Thank you. And I just wanted to follow up, going back to some of your recommendations on the Chief Medical Officer of Health's role, and specifically some of your comments earlier. You mentioned in the report one recommendation was to immediately assess the role and strength of the Chief Medical Officer of Health to lead Ontario's response. So can you just clarify a bit further? Were you critical of the ability of Dr. Williams to perform in this role, or the structure of the role itself, or both?
I think we're commenting in the report on the feedback that we got in talking with people that work in this field and in the different areas that have been affected by COVID. And I think, one example would be there exists the opportunity to bring together the public health unit heads, the 34 medical officers, and discuss areas where there can be consistent communication. So an area that could have happened in is the area of masking. So in our report, we have an appendix, and we do indicate that there were differences in the ages of at what age would somebody wear a mask, and that's a good example of where they could have come together and, discussed what would be the consistent message in the province of Ontario. So there's an example where, the public health units themselves thought had messaged.
Brian Lilly, Toronto Sun.
Ms. Lysyk, just to return to Sneha's question, I understand your role in examining functions, where plans followed, things like that. But when you get into medical advice, you actually contradict yourself. On the one hand, you are critical of the government for testing asymptomatic people, but also critical that they weren't testing asymptomatic people who were travelers. You do this multiple times throughout the report when you get into medical advice. Is it the role of the Auditor General to evaluate medical advice and how governments act on them?
I guess I think I'd correct you there in saying that I don't think we're saying that asymptomatic travelers should have been tested. I think what we're saying in the report is that there were millions, quite a few, over 1 million and some odd people that traveled into Ontario over a number of months, and that the federal government did not report to Ontario that those people were in Ontario to enable the contacting of those people to talk to them about isolation, not to talk to them about testing. Most of those people wouldn't have had symptoms. So on that front, I just want to clarify that. And in terms of medical, we actually, there was a gentleman that you're probably aware that was involved in the SARS writing, and he did work with my team, and that's Dr. David Walker. And he has gone through the reports and looked at the reports and thought they were pretty good. In terms of medical expertise, I once again say that the contents of these reports were vetted for factual accuracy by all the stakeholders that are mentioned in this report: Public Health Ontario, the Ministry of Health, Ontario Health, Secretary of Cabinet got reports, and they agreed to our recommendations in these reports, and that is documented. So I think that we have enough confidence in our work and in our reports to be very happy about those products, and that those recommendations are important ones that Ontario needs to implement to make sure the next time a pandemic hits that we're prepared, better prepared. That's not to say, that's not questioning the fact that, 15 years from now, some of those plans could still be, could have been updated and get up to date again. We're just saying right now, you have the experience, you have the knowledge, you're dealing with the pandemic. Help that process along so that when the pandemic is done, Ontario is still positioned to deal with the next one well.
All right, since you said you wanted to correct me, allow me to correct you on what's in your report. Page 46 in the printed edition, page 100, in the PDF version, you actually talk about at 4.3.2, the ministry discouraged having most travelers tested for COVID-19, despite COVID-19 being found in many countries. So you actually were critical of the government on that. But I want to ask about the fact that the pandemic plans were not updated for years. Minister Elliott said that it was simply a matter of testing and issues around that weren't updated. People in the previous Liberal government said that they did a lot of planning around this. So when you say that plans were not updated, are you saying that there was no pandemic planning, or that an official document that you felt should have been updated was not updated?
Let me start by saying that I just want to reiterate, because I think you're looking at the report and you're going, gee, this is a questionable document here, and I want to say that report, these reports, have been vetted for factual accuracy, and I have letters signed by all the senior people within the province that attest to the accuracy of the information, have agreed to the recommendations, and have incorporated their responses. If that is changing now, then I guess some people signed letters and gave them to us and represented factual accuracy when that isn't the case. And that would be a problem. At the end of the day, in terms of the, in terms of the approach, it's not, my hope on this report is people look at it and focus on what needs to be done to go forward. Not to use it as a blame tool, not to be defensive against what's in this report, but to actually use it and to implement recommendations that were made in the last 15 years over and over. Like, why do you think that recommendations that were supposed to modernize the IT system of the public health system or modernize the IT system are bad? And why aren't we talking about how to implement things to make everything better rather than arguing a little bit of minutia around the report? That, So I guess my hope on this work is that things are changing to implement improved processes. People have made decisions. I don't think we're using the report to say that their decisions were wrong. What we're saying, the circumstances that they were put in to make decisions could have been better, and and those systems would have facilitated more timely or more fulsome actions.
Laura Stone, The Globe and Mail.
Yeah.
Hi, Auditor General.
Hi.
I wanted your answer to this. The statement in the report, the Chief Medical Officer of Health did not lead Ontario's response to COVID-19. So who did?
Well, I think, the decisions, all the command table and the coordination table were advisory. So the command table was chaired by the Deputy Minister of Health, and sometimes when she wasn't there, it would have been chaired by Ontario Health. The recommendations from that would have went up to the coordination table, and that was chaired by the Secretary of Cabinet and the Chief of Staff to the Premier. And then those recommendations would have gone to the Cabinet and Premier.
So what exactly are you saying here? Are you saying that the decisions were overly political? I mean, I know that you're kind of resisting making judgments here, but in statements like that, you've really dropped a bomb on Dr. Williams. So what exactly are you trying to get across? Do you think that he should have or could have taken a stronger role? Do you think the decisions were done politically, or what exactly do you mean?
So we lay out in the report the process. The decisions were made by Cabinet and the Premier. In terms of the Chief Medical Officer of Ontario, he provided advice into the command table, which then provided advice to the coordination table, which then looked to a decision by Cabinet and the Premier in Ontario.
Christina Tenalia, CP24.
Hi, Auditor General. My question touches on some of the questions already by my colleagues. I know you just answered Laura's question similar to this. You noted that Dr. David Williams did not exercise his full powers and did not take on a leadership role. I'm wondering, is your sentiment that he was muzzled, or was this him making these decisions based on his medical expertise?
We've talked, we talked many times. My staff talked more than I did, but I've talked to the doctor as well. And I think he recognized that he was working as an advisor into the health command table. And that is factual.
You also talk about how it was the Premier that was the face of this, and the Premier and his cabinet made the decisions. I'm wondering your sentiments on this as well. And you've noted that, these health command tables, these are advisory roles. Should it not be up to elected officials to make decisions based on the best interests of the province? I mean, what is your sentiment on that based on your investigation?
Yeah, I think the report lays out the way it was. And I think what we're saying in terms of the health response is that if there are decisions that flow from, let's say, Public Health Ontario and from your Chief Medical Officer into, let's say, the coordination table, then if there's a difference from the, those recommendations, what we've recommended is that there be communication back to, let's say, Public Health Ontario, or that explains, and to other stakeholders out there who commented that they didn't understand sometimes why decisions were made the way they were and they weren't given enough notification. So, part of our message here is you need clear lines of communication to make sure everybody understands the basis of decisions. And that's why it is positive to have an emergency management framework that clicks in so that people understand roles and responsibilities, and all those clear lines of communication are in place.
Mike Crawley, CBC News.
Auditor, you mentioned the fact that a consulting firm was hired at a cost of $1.6 million to develop the command structure. Could you comment on the effectiveness of this spending and the effectiveness of the command structure that the consulting firm created?
Yeah, so when, there wasn't an up-to-date emergency plan in place, and, I reviewed this, the Secretary of Cabinet, along with the government, decided that they did need some structure, and they did bring in a consultant to help them set up that structure and tables, and to put in place something that they could work with. The benefit of that is there is a structure and there is communication. The difference between that structure and what would have been in the emergency management structure is more command and control versus advisory. So the structure that's been designed is one of advice. So there's a movement of information up the chain to a decision maker. When you trigger emergency management, the roles and the decision making is already predetermined. So at a table that would have been created under emergency management framework, which is called like an IMS framework that's used all across Canada, it would have been a table of deputies. They would have been delegated roles and responsibilities, and they would have made the decisions that were delegated to them, and decisions that they couldn't make would still be pushed up to government. So what you have is the new model is one more of advisory. The formal one that's used, in emergency management is more of a command and control.
You often comment on value for money. Do you have any view on, or what is your view on whether taxpayers got value for money out of the $1.6 million paid to the consultant to draw up what effectively seems like an organizational chart? And I think you said that there was another $3.2 million paid to the same consulting firm for the reopening framework and consulting on the school reopening plan.
Yeah, we have the dollars in there. We write with full disclosure. I think if at the time there wasn't a plan in place that Secretary of Cabinet and the government thought was going to work for them, then we needed a structure, and they found one and they put it in place. Our comment on that is, if the emergency measures management plans had been kept up to date, they wouldn't have had to go that route, right? But out of necessity, they went that route. So we needed it. It was done, and I think that's what they've been managing in that framework. So, the situation was such a shock that it was a disaster, right? And so they did what they had to do. I think our only point on this is that you need something like that to be available to you when something like this hits. And that's the whole message around the emergency management planning that was needed to have been put in place for the last many years.
Graham Richardson, CTV, Ottawa.
Hi there, Auditor. I just wondered about big cities. You hit it several times about contact tracing, and you point out that the hot spots, for lack of a better term, the position they're in now is linked to their lack of ability to keep up with the provincial standard. Do you draw a straight line to where they are now with what happened between March and August?
So in I believe it's figure 17 in our report, we have the two charts, and we show what the impact on the time that it took to complete testing and the additional time it took before case management was started. And then we also have another one on contact tracing. So the key is to minimize the time from the time there's somebody gets tested to getting their results, to then contacting them for case management, and then tracing. And so we do have the data there, and it does show in those charts that it's figure 17, figure 18. It does show that the targets that were set, remember these are targets that were set by the ministry, and they were having trouble reaching the targets that were set by the ministry. And then in terms of, and that was for lab tests completed within 1 day and 2 days. And the reason that's important is because the longer it takes to get the result back and to go into case management and contact tracing, the spread can happen faster. But if you can reduce all these times, then you can contain the spread. Yeah, sorry. Yeah.
Okay, fair enough. And just following up on some of my colleagues' questions, I'm just going to be very blunt here. It sounds like Williams is not effective from your perspective, and Williams is taking his lead from the political people. And that's wrong. Is my characterization too harsh, or is that what you're saying?
You know, I guess what we're saying is that he provided advice to the health table, and that advice to the coordination table, and advice to government. But the ultimate decision making is government. And you know, governments can make decisions. I mean, you know, I think the disconnect we saw here from the discussions with the public health community was that when their advice is not followed, they just want to understand why it's not followed. And there could be very good reasons because, you know, governments have to weight economic decisions against other decisions. And so all we're saying is he did operate in an advisory role.
Just a couple of questions from me, and these are the final ones. Did you uncover any proof, any evidence at all that the advice given to the government from Dr. David Williams was ever ignored?
There's a few situations we cite where you know, the advice that was provided by public health experts that went into the health table, that then went up to the command table, that was used, wasn't followed. So asymptomatic testing is one of the pieces of advice that wasn't followed. The other one is the testing of visitors to long-term care homes. So the advice from the testing strategy panel, I believe, is that that test is as good as the day you get it, and that creates a sense of security that might not be there the next time somebody goes into the long-term care home. So that person shouldn't, you know, the test gives them that comfort that they don't have COVID. Well, it's a day-to-day test. So they advised that one. And there was a third one. Gigi? Oh, yeah. So, right. So the COVID response framework was put forward, by Public Health Ontario through the health table, and that was changed, and I think that was pretty much in the media quite a bit. And yeah, even the one that exists today doesn't exactly match the recommendations of Public Health Ontario.
And just finally, you're calling on the government to make all of the advice that it receives from its public health officials public. Why do you think that's important? How would that serve the public?
Well, I think transparent. I think, you know, in talking to people, some of the decisions, people just need to understand the decisions to sort of gain acceptance with the decisions. And so that would be important for the people that work in the public health community. It would probably be important for all of us to understand, you know, rather than hearing a debate in the media between public health experts and the province. You know, I think if there was a fulsome reason why governments made a decision to do something that was different from some advice, and they have that right, that it's transparent.
More questions? Thank you very much.
All right, thanks. Thank you for your questions.